Ian has asked me to talk a little bit about scaffolds, and I'm not really going to talk. What I thought we'd do is have a conversation. So first of all, who's used a meniscal scaffold? Surgeon in the room. Okay, who hasn't used a meniscal scaffold? Fine, okay, so that's what I thought would happen. So what we'll do is we'll have a mixed ability group conversation. And just to give you a sort of sense of where I am, I have only really just started using them. I've done about 10 now, and I think that it's a very interesting topic. And like most of the things that we're doing, what we're probably seeing at the moment is what John Charnley saw when he started putting hip replacements in. In other words, he thought, I'm onto something here, but it's not a fully resolved product yet. So we're getting something which we hope works, and I think we will see a fairly substantial development in time. So at the moment there are two products that are on the market. One is the CMI implant, which is collagen, processed collagen. This is the one that I have used most of. It's something which some people say is a little bit more difficult to handle than the other products on the market, which is polyurethane, and I'll show you that in a moment. My personal view is it's not particularly difficult to handle. The principle behind scaffolding, which for those of you who don't know or haven't done it, is that you can use the scaffold when you have a meniscal defect, but you do have the anterior and the posterior horn. So you've got something to sew the scaffold onto, and the principle of the scaffold is that cells grow into it and you end up with some regenerate. The other thing that's important, and you can see on the right, is that there needs to be a rim. You can't use these when there is no rim of meniscus. And so the critics of this type of technique would say, so what you're doing then is you're putting something in where you have still got a pretty reasonable meniscus and you don't really need to be doing an operation at all. That's not my view, but that's certainly what some of the critics say. The technique, I'll just go back, the technique of doing it, there's a pointer here.
It doesn't work very well.
Does it not? Okay.
Yeah,
Thanks. So the technique of doing it, again, for those who haven't done them before, it's this one here. Thanks. It's pretty simple. It's an arthroscopic technique, and what you do is you make a nice sharp edge here and here. You measure this distance, add 10%, cut this on the table, bench work it, and then with a pair of curved forceps, put it in and stitch it all the way around. Now, normally I start at the back here, and then I use stitches like this, and then at the front I'm going to show you a little trick machine. I learned this technique on a hospital innovations course, cataract course. I have to say I owe a lot to that company. It was a fantastic course, and if you can do it, I would definitely do it, because they gave us loads of these things to use and blinking expensive. So it was great. One of the tricks I learned was to take a big suture, and I'll show you the machine in a moment, and once you put this in the knee, to hold it in place, you put the suture out through the knee here and underneath. So you've got a loop and you're holding the implant in place. And this is the thing, sharpshooter. For those of you who've seen it, you'll know how it works. Effectively what you do is you feed this very long needle down through the system. The gun fires it through and it goes out through the side of the knee. And by holding the meniscus in place whilst you get the first few sutures in, it makes life very, very much easier. And this is pretty much what it looks like. There are lots of proprietary things here. This is a Fast Fix 360, which you can use around here. And then at the front, you can use the sharpshooter to get this bit, or you can use an outside-in technique. So when I first started doing it, and we had a question earlier on, which I thought was a really interesting question about, how do you start doing these? And certainly my experience of it is, like all of these operations, you walk into theatre on the day you're going to do your first one, hyperventilating slightly and thinking, crikey, I hope I get through this, and I don't drop it on the floor and it doesn't all fall to bits and so forth. And then as your experience grows, you begin to realise actually this isn't as difficult as I thought it was going to be. And I can do one of these now literally in 30 minutes. Admittedly, I always do it as a two-surgeon case, and my knee fellow helps me, but it really, really isn't very difficult at all. And if you're lucky, you get something that looks a bit like this, where there appears to be some ingrowth. Now, there obviously are all sorts of photos like this that you can look at, and they don't really mean very much, apart from the fact that someone's taken their very best result and taken a photograph of it. So what the results look like? Well, like all of these studies, of course, they're small studies from single centres, and really, as to my knowledge, there are not large centre studies. But, you know, they're pretty encouraging, really. So, 34 patients, 2 and 5 year follow-up, all the scores improved, no further articular cartilage degeneration so far as they could tell with MRI scans. And what's interesting is that when they go back and scope them, the meniscal appearance continues to improve with time. And certainly my experience from ACI and MACI was that the results get better, and we often try and assess them a bit too early because the cells take a while to grow. And another study, again, it's just a sort of prospective long-term study by Zappanini, 33 patients. And this is interesting because they all did well. He followed them 2, 5 and 10 years. Patients chose a treatment between meniscectomy or a scaffold, and the CMI had better scores, less pain, less deterioration in joint at all time periods, but this is kind of interesting, isn't it? And I think we shouldn't be put off by this. You know, inevitably, some of these are not going to work, and I suspect in time what we'll see is we'll learn how to do it slightly better. We might add cells to these things. We might use a bit more fibrin, that sort of thing. So the second one on the market, Active. This is a polyurethane. When you look at it, it does actually look a little bit like a sponge. Studies, again, small studies, 18 patients, scores improved, but the tenure was not up to its pre-injury level. Bigger study, Peter Verdonk, and James and I are going out a little later this month to have a look at some of the work he does for a day. Bigger study, and what's encouraging is they definitely saw quite a lot of ingrowth on MRI scan. All but one showed integration at 12 months, and they also biopsied them, and they all showed viable cells. So I think what we can see is that we've got a technology which is promising. And there's emergent technology. So there's a new product that's coming out, multi-layered silk scaffolds. They're running a study in Bristol on this. And James, have you got anything to say about this? I've had no experience with this whatsoever.
Okay, so this is it's a first-in-man study only. So far we've recruited 4 people, we've implanted 2. It's Ashley Blom as Prof and Andrew Porteous is the lead surgeon on this. So we put 2 in. I was there for both cases. Andrew was operating, I was just in theatre. And it's a harder implant to put in than an Activate, just physically it's harder. But they both went in, and 6 weeks afterwards we've not had any problems. So very, very early days.
Did you cut them to size, James, in the same way, or was it the whole?
Same way. It's much, much harder. It's really quite hard. So when you push into it, it's quite a resistance as you put a fast plate into it.
What's the proposed advantage of it compared to
the advantage? Who knows? We don't know. It's another technology. I mean, silk is fantastically biointegratable. It will integrate well, and it's very, very strong.
They've designed the...
hopefully it will transmit load better.
They've designed it so that it has fibres that run in different directions. There's some way to try and reproduce the hoop fibres.
Hoop fibres, yeah.
Is it more a replacement than a scaffold?
No.
Well,
no, not at the moment.
No.
It's still a scaffold. That was what I asked.
Well, they're a replacement of a scaffold to some extent.
Dissolve though, whereas the other 2 do.
No, it's a replacement. it is a replacement in that sense.
Yeah. So,
It's not meant as a whole meniscal.
Sure.
the last time I was at ESCO last year, a number of people were presenting their results using these, and most of them were talking about an 80% success rate, roughly, patients being happy, getting back to doing the things they wanted to do, their pain going. The ones we've done, we've got people up to a year now, they're all happy. Of course, it isn't really a study at all, in the sense that we don't have any sort of hard data. But one of the things that was very interesting was that the people who were presenting their data presented it in a very modest way and said, well, you know, we're very careful who we choose, and we're not really sure whether it's going to work or not. And someone said, why are you being so bashful? You know, if they are 80% successful, which is what you're telling us, I mean, that's pretty good, isn't it? I mean, that's better than lots of other things. Should we not be, and this is really the question that I'm going to ask you, should we not be putting more of them in? So when we take out menisci in young people, instead of waiting until they degenerate their articular surface and need a meniscal transplant, should we not be putting more of them in? I have no idea what the answer to that question is. I'm just going to throw it out there. And so now we'll just have 10 minutes discussion about this.
Can I ask what your criteria? How do you select your patients?
Well, it's just as you would imagine, in the sense that I've just sort of started on this road. I'm a cautious chap, and so I will put them in people who have had a substantial meniscal resection, who come back with symptoms, namely, I've got a knee that's painful. They've often got, on an MRI scan, a bit of bone stress either side of the joint, and they've got a rim and they've got horns either end, and so we think, okay, we'll do it. So that's where I am at the moment. So I'm sort of doing what is classically described as how you should do it. But I'm beginning to think that we should perhaps be a bit braver, really.
Have you got any feeling as to the size of the defect? That would give you better success. My feeling is the more contained the meniscal defect is, the better the results.
Yeah, I'm sure you're right, and I'm also
So in other words,
sure...
it's going to be it's a symptomatic small meniscal tear that you've got with really hard edges.
Yeah.
You can plumb it into rather than trying to be a bit ambitious, in which case I think you better be going for a whole meniscal.
Well, I think you're absolutely right, and I also think that what I'm personally probably going to find as time goes on is that we've been a bit ambitious in some of them, and there's certainly one or two that I've done, and I've looked in there and thought, oh dear, should have done a transplant on this, and I'm sure we'll find that that's the case. But the other thing I think is really important to understand is this isn't like putting metal and plastic in someone's knee. So let's imagine, worst case scenario, get it wrong, thing fails, have we lost very much? Probably not, as long as it's not infected, as long as you haven't left the joint so that it's worn out. This is why I think we need somehow to agree amongst ourselves how we're going to approach these sorts of problems, so we can kind of start doing them and then get a bit more data.
Yeah, admittedly extremely small numbers, but what is your percentage of those 10 numbers? How many lateral, how many medial?
They are...
patient, and also...
honestly, I have come here to talk to you about this, and I honestly don't think there's really very much point in me telling you those things, because they mean nothing. I mean, I know for a fact that we've probably done about, I think it's 7 medial and 3 lateral, but it means nothing, if I'm honest.
I present a slightly more cautious view of the use of these.
Right.
Having followed up our ones, we've stopped doing CMI probably 5 years ago.
Yeah.
Because they all seem to fail. Lateral side do much worse, over a 50% failure rate, and that's the side that's more important. I think all of the studies, and people are bashful and modest about it because none of them are actually controlled trials.
No, none.
There are 3 controlled trials of the use of these. One of them includes patients, all patients had osteotomies, and the study was, does adding one of these make a difference? And the answer was no. The other 2 studies, controlled trials, one of them was done by Dick Steadman, who developed the CMI and showed no difference. and the other study also showed no difference. So there isn't actually a comparative study which shows an improvement of these. There's only a small case series, and maybe if we gave our patients an arthroscopy, well, no, sorry, other way around, maybe if we gave them a very structured rehab program of being off their feet for 6 weeks and very structured physiotherapy, they might also have the same improvements. So, sound very negative, I'm just again being balanced view here.
Yeah, I think that's right.
We still use them in very occasionally, but have moved much more over to actually doing meniscal transplantation. And I think the problem in my mind for the use of these is that the ideal patient is so rare that they come, because you don't see that many people with a small segmental defect that this would be great for, these are great for, who are actually symptomatic. Usually most of the meniscus is gone, there are alignment issues that you're going to be correcting anyway, so I'm a bit more cautious about
But I think this is the interesting point, and I agree with absolutely everything you say. My question really is this: up to now, have we been using these things, have people been using these things on patients who really should be having transplants? And in fact, this should be used at this stage for people who aren't symptomatic, but who have lost a substantial amount of their posterior horn and medial meniscus, for example. I have no idea.
Quite possibly. And just a final point is that photo, was that your photo? Or was that, no. So, seeing is believing, and you never see anybody show you their post-op videos of beautiful looking meniscal scaffolds. I've got one, which is the best one I've seen, and it looks rubbish.
Yeah.
So,
my personal take on this is that I think we're going to really struggle with. I think we're going to really struggle to ever prove that these meniscal scaffolds are actually worth putting in, because the indications are really quite narrow. You've got to have a segmental defect that's big enough to justify it, and not so big that it's too big. It's got to, the articular cartilage has got to be in as good condition as possible. You put these in somebody with grade 3, it's going to fail. Right? The rest of them has got to be perfect in terms of stability and alignment. But it's so multifactorial that you're going to end up with this real homogeneous mix of people. The perfect case is so rare that they're being put in knees that are just too far gone. I've put them in, just like Pete and Tim. I stopped doing it fairly reasonably promptly because I just was not happy. When they fail, they are shredded.
What way were you not happy with them?
Because I was taking out as many as I put in. Because they're just.
When did you take them out?
As quick as 1 year post-op.
Oh, really?
Sooner. Yeah. And
I feel like Neil, I've done 7 over about 5 years. So they're rare.
Yeah.
Haven't taken one out yet.
Right. Maybe just unlucky. But
For
my
were with osteotomy. So whether it's osteotomy.
well, exactly. From my perspective, if it's bad enough to justify meniscal replacement, I want to replace it with a meniscus. And I don't think there's anything available yet that's as good as a meniscus, that's better than a meniscus. And Angus Strover used to say that there's no reason why you can't use a meniscal allograft as a scaffold. I'm talking about the practicality of it. You could actually get a meniscal allograft, cut it to size and to fill a segmental defect and stitch it in. And then you've got biological tissue if you wanted to. Personally, from my perspective, I honestly think that the case where you've got a perfect anterior horn, perfect posterior horn, not just talking about the insertional ligaments, we're talking further round, like the third, right? And you can make a clean cut. Is really unusual, really quite rare. I think the future, if you want to say what's going to happen when us lot are retiring, I think the future is bioengineered, 3D printed, meniscal scaffolds that are complex. Right? They're going to have fibres in it. They're going to be complex. There's going to be some kind of weird transitional zone at the attachment point. It's going to be seeded with cells. It's going to be put in a bioreactor. It's going to be a living scaffold with cells that's going to be implanted. That's almost definitely what's going to happen.
That you put in prophylactically.
Yeah.
I mean, that's getting back to your point, James, earlier about you need to be keeping some record of these patients. And the problem is that there's, you go on a course, you learn how to do it, and you just go completely over the top in choosing who you put them in. And we've all done that in the past, and we just need to be really careful about what we do. And I totally agree. I think the ideal is that scenario you painted, they're put in prophylactically, but to get to that point, we've got to be sensible in who we choose, and we've got to follow them up. We've got to have some sort of registry. It's
But if
registry for everything.
people are not brave enough,
it's important.
if people are not brave enough to actually innovate, we're never going to get there.
Yeah.
You've got to have people doing what you're doing, and you've got to, be incredibly interested to hear your results in a couple of years' time.
I think that's
Really
that's one of the reasons that we're going to go over and see Peter Verdon, see what he's doing, because certainly my fellow's been over there, and he says they do a lot of these, and they put them in people who we probably wouldn't. In other words, they don't come back saying, I've got a painful knee. They do a posterior medial meniscectomy and put a scaffold in there and then. Anyway, what that brings us to is lunchtime.